Good afternoon. I'm Gina Vild. I'm the Associate Dean and Chief Communications Officer for Harvard Medical School. And thank you for joining us today for this very special talk at 12, Disparities and Bias in Global Health. The Talks at 12 were launched 8 years ago as a way to share the extraordinary knowledge of our faculty with others on the quad. Today we live streamed this event and all of our Talks at 12, and it's not unusual for them to be viewed in 36 countries by 40 or 50,000 people. So I want to welcome all of you here today and the NRB, and also those watching from around the world on live streaming. I do welcome your topics. I invite them for future Talks at 12, so please send me your ideas. We are thrilled to have with us two HMS experts on healthcare disparities, Dr. Paul Farmer and Dr. Joan Reede. Dr. Farmer and Dr. Reede will discuss how socioeconomic disparities among the medical community may contribute to inequitable healthcare outcomes here in the U.S. and around the globe. And they will share their thoughts on how healthcare providers can improve healthcare access that will lead to healthcare justice for all. Dr. Paul Farmer needs no introduction. His work as a humanitarian is well known in far corners of the world. A medical anthropologist and physician, he has made his life's work delivering the most seminal care to the poorest of the poor in many different parts of the world. Beyond this, he also works tirelessly to improve human rights and the consequences of social inequity. Dr. Farmer has been a member of the Harvard Medical School faculty for more than 3 decades and is currently the chair of our Global Health and Social Medicine Department. He is also the co-founder of Partners in Health, an international nonprofit organization that directs healthcare services and initiates research and advocacy on behalf of those who are ill and living in poverty. A history of this transformational work of Partners in Health, the work of Dr. Farmer as well as Dr. Jim Kim and Ophelia Dahl, has recently been captured in an exceptional documentary called Bending the Arc. I have seen it and highly recommend that if you have an opportunity that you try to see it as well. Our moderator this afternoon is Dr. Joan Reede. She is Dean for Diversity, Inclusion, and Community Partnership. Dr. Reede is a professor of medicine here at Harvard Medical School. The impact of her exceptional work is reflected in the many programs she has created to benefit minority students, residents, scientists, and physicians. Her work is changing lives. She has launched more than 20 programs that address pipeline and leadership issues for minority and women who are interested in careers spanning medicine, academia, and biomedical research. She leads Dean Daly's task force on diversity and inclusion. Thank you both for leading today's discussion. It'll be a conversation. I know they'll welcome your questions at the end of their talk. And I also invite those of you who are watching from afar to please submit your questions on Twitter at #@TalksAt12. That's #@TalksAt12. So thank you for joining us, and thank you, Dr. Farmer and Dr. Reede.
Thank you.
So Gina has done this wonderful introduction, and thank you for that introduction. But I have a slightly different view when I think about Paul Farmer, and I think of him as a friend and someone with whom I share common values about justice and equity, but also someone who believes that the impossible can be done. So I want to open this with my introduction of Paul, and he's not heard this. And I'm taking this
I'm
from
scared.
I'm taking this from Muhammad Ali, a man who stood for his principles also and a fighter. And Ali said, "Impossible is just a big word thrown around by small men who find it easier to live in the world they've been given than to explore the power they have to change it. Impossible is not a fact, it's an opinion. Impossible is not a declaration, it's a dare. Impossible is potential, Impossible is temporary. Impossible is nothing. And when I think about your career and what you have done in moving the world, I think of someone who saw impossible and said, let me push this aside and let's continue to move forward. So if you think about the topic for today around disparities and bias in global health, your work has been around these inequities and injustice. How do you relate that to disparities and bias? Where's the link?
Well, first of all, that's a beautiful Ali quote. I mean, I'm often compared to him, so
I can see why.
Used to that. You know, I just assumed when I saw this invitation that these were the same thing. Right? It is you know, global health, and this is just a personal definition is the wrong word. It's more along the lines of Ali's definition of impossible. And I'm sorry if I've told this before, but I don't think I have here. But I went to Haiti before I came to Harvard. And I applied to Harvard Medical School from there. And this was in 1983. I came here for the first time in December 1983 for an interview. And you know, to do that trajectory from Harvard to Haiti in those years, or from, you know, later the Brigham to Roxbury, let's say, or to, you know, you go right down the list. We've discussed this many times before. It never occurred to me that global health could be anything but about the globe, and that Charlottesville's on the globe, and Boston's on the globe, and on down the list. And then I look at some of my teachers who are in the room today, and I understand that in their view as well, they had this transnational, whatever you want to call it. I mean, it sounds highfalutin, but this transnational political economy that has long defined our world. And so, to me, those are always related problems. You know, the specifics of bias and the specifics of health disparities in, let's say, an epicenter of medical knowledge here might not look the same as health disparities in another place in that global economy. But one, it was usually possible to find some trace. I mean, I teach this class with, again, colleagues from Harvard Medical School. We teach it at Harvard College. Arthur Kleinman, Ann Becker, Salman Khashoggi. And we've been teaching it for a long time. And yesterday, it's my turn, and tomorrow's my turn. And the topic was Ebola. But I really wanted to talk about health disparities and to have them, these students, most of them very young, and more sophisticated than I was when I was an undergraduate, understand that where they're going tomorrow, where I am actually going physically tomorrow, but where they are going intellectually tomorrow, is through that triangle: West Africa, North America, the Caribbean. And you know, that's just one way to see, one truthful way, non-fake news way, of seeing health disparities. And I know there's a long answer, and I'm sure you're shocked by it. I am the Muhammad Ali of length, however. You know, it's just the erasure of history and the desocialization of our social worlds is part of the problem. And you know, that's part of the problem among medical professionals. That's part of the problem among medical students, residents, faculty, all the way down the line. It's our problem, right? And so that's about as short as I can go. But I don't see the value in doing what I often hear is, oh, well, that's, you know, you think this is bad, you should, and that's just the common reaction, and a common reaction.
And disparities hurt no matter where you are.
Disparities hurt, and we need to be able to identify where they hurt most and how they hurt most. And and I was reading W.B. Du Bois yesterday, who I've been calling W.B. Du Bois for about 30 years until my daughter corrected me, and on the way back from Haiti. And just, he was writing about the same erasure in his time between Western, the same historical relations. He grew up in Western Mass, went to Fisk because he couldn't get a scholarship because he's African American. Then he did go to Harvard and eventually became the first African American to get his PhD, which was before really the creation of sociology, history, political economy. But that's the point he made again and again in the part of the book that I read on the way back here, is that the erasure of history is one of the mechanisms by which we perpetuate structural violence, or whatever you would care to call it.
And keep the structures in place. How is you talk about something that is truly global? No matter where you turn, these issues of disparity and injustice and inequity exist, and lots of this is structural. As a health professional, as a provider, what is our role in addressing that, or do we have a role?
Well, you already know that my belief is the same as yours, that we do have a role. And I think that role is really roles. For example, if I'm doing an infectious disease consult at the Brigham, and I know that structurally determined forces like gender inequality and racism have worked themselves into the body of a patient, right? That's not why, like, the surgery team is consulting me on a patient. And, to ignore that, meaning to ignore the fact that these forces get in the bodies of patients as they do in the bodies of our colleagues and our students, to ignore that is always wrong, I think. But there's a way of maybe. I mean, remember, this is a conversation.
Right.
I'm not assuming that I know the answer to that question. All I can say is I struggle with it mightily, right? A number of our colleagues, my colleagues from Harvard Medical School, in 1996, we wrote a book called Women, Poverty, and AIDS. I know you've read it. Everybody seemed to buy it like hotcakes. And, Mary Jo Good contributed, Joe Radigan, a lot of people you know, Johanna Daly. There's no question that we could at least try to trace how social inequality, social disparities, structural forces, you say, get into, in this case, women's bodies. But during an infectious disease consult, that's really not what you're being consulted on. It's like, that's the wrong dose of this, you might want to try that, here's the combination of antibiotics. That's the job. And the problem is that then do we back away too much from confronting structural forces that we weren't trained to take on? Actually, as an anthropologist, I was trained to do it, but not as a med student, a resident, or a fellow. And I know the answer to that also has to be, yes, we certainly do move back too quickly. And that's one of the reasons I love being a teacher, whether here or in Haiti or anywhere else.
So there's these structural forces, and you have to figure out, in the Kenny Rogers, know when to hold up, know when to fold up, know when to act. Yeah. And what's your role? But what about the forces that we bring into the room at the same time?
Well, that's the thing about humans. There's no structural force that we're talking about that isn't brought into the equation by us. Right? And that means that I would assume that they can be undone by us. And they also affect us in bias that we're willing to acknowledge or not. And I think the exercise of trying to sort through that, as humbling as it is a good one. We don't do it very well in a clinical setting, or it sometimes gets formulaic, like a checklist. But if you have a fellowship program, for example, that goes on over time, that's not just a formulaic response. If we have, acknowledgement that we have a serious problem with all this bounty that we have, that's better than saying, we're doing the best we can, or these are forces that are determine, the fates of either faculty or patients or students or patients before we can get our hands on them.
So there's a piece of this, though, as you even describe, you're this infectious disease consult, and you're sort of saying, my role in this is to say this is, antibiotic is better than the other, or how to treat. But if you take it to that next level of who's determining what antibiotics would be available in the formulary.
Yeah.
And so it's not just for that patient, it's how you interact with that system around that patient that may or may not make that available. So I look at some of the things that are going on in the world today. What's available in one place is not available in another. And as a provider, isn't there a part of it where we need to step back and say, we need to speak up about this, that it's not right, it's not fair?
Well, that's been the great drama of, I say our work. I'll say my life too, because it's true, but it's never, I mean, that's the best way to be able to do nothing is to think of this as an I problem, right? But I'm looking, and again, looking around the room, some of my colleagues from Harvard and PIH, Partners in Health are here, Louise Eibers, and on it goes. This is a great drama of the clinical work that we do. That drama is lessened whenever we have the right staff, space, and systems. And so the global disparities, which I knew you'd bring up and I'm relieved because I feel like that's in my wheelhouse. They're material manifestations of bias. And I don't want to go overboard on the materiality of the social, which is a title of a paper that I once gave, and I'm sure you've read it, along with my mother. Cool title, though, Materiality of the Social. But that was the point. Like, how do you, in this particular case, I was talking about the distribution of HIV disease or tuberculosis in a global sense. But that's only part of the way that bias gets in. Because what about after distribution of these? Then there's the fact that we know in a global political economy that there is some tool. And of course, you're going back and forth from Harvard to Haiti, then you really know it, right? You're reminded. But I'll just give an example because I just saw Louise come in. The only other time I've given a talk at 12, I know you know when it was. It was my first talk after the earthquake in 2010. And it was very difficult to do emotionally. And, I was, I was nervous about doing it. Claire Pierre came. I think Louise was probably still just working there in Haiti. And, I thought, I really want to get this organized so that I don't have, a difficulty expressing myself, what with being the Muhammad Ali of global health and all. And shortly after that, one of the great complications and horrors, not a complication of the earthquake, because this would have happened with or without the earthquake, was the introduction of cholera. Now, the introduction of cholera was obviously a manifestation of precisely those structural forces that you're talking about. Came from, it happened to be Nepal. Again, if you look at the history of the great pandemics of cholera, there's always they're translocal, they're transnational, and there's enormous blame and suffering both that happen. And then they run right along the fault lines of social disparities. But this is the last time there was a big epidemic in the Americas. I happen to have been involved in that one too, because it went from Peru, where I just started working, all the way up, Latin America, across the Caribbean, another disaster. Unknown in Haiti, as far as we can tell. And, but the difference between 1991 and 2010 was that there were new tools for the diagnosis and prevention of cholera. Old tools for the care of cholera, right? But there were some new tools too, including an oral cholera vaccine. So that is what I mean about, I know that doesn't sound like a punchline, but I'm just saying, therefore, in the view of those acknowledging that transnational global economy, which should be all of us since we're all part of it, there were tools, and just to say, well, they're not cost-effective, available. And that's exactly what happened, even though people like Louise and her Haitian colleagues fought like hell to make sure that that didn't happen, but it did, you know. And now, who were the people we were arguing with? There were Haitians who were running away like superstitious peasants. Again, the accusation of the colonial authorities across Africa, right? It was our own peers. Again, that is, people who had trained with and like us, who looked like us, who sounded like us, regardless of what language they were speaking, by the way. That to me, that's disparity and bias in global health. And so how did it get into them? How did it get into us? And it is obviously through our professional socialization. If it's not an 18-year-old, it's not going to give you a lecture about whether or not an oral cholera vaccine is effective, cost-effective, sustainable, or might possibly distract people from washing their hands. But that's exactly the kind of discussion that we expected and heard.
So that bias and that ability to judge what people should and shouldn't have access to, or who's deserving and not deserving is another way to think about it. How do you counter that? In medical education, as we train our students, be they nursing or dental or physicians, but how do we also counter that in the faculty that train the students?
Well, I mean, I would argue, and again, I love how this has turned into Joan revealing Paul's
Why not?
uncertainty. But I'm not trying to sound like a guru, and you know that, and I don't know the answers to these questions, but I do not think the answer to that question can be only by understanding health disparities and their distribution. Now, an 18-year-old probably could guess what the city of Baltimore might look like in terms of health disparities, right? And that's an important task, to learn about the burden of disease and health disparities. But if there's a materiality of the social, then the response has to include activism, engagement to counter the inequalities.
Right. And a history, understanding history. So part of this is this history and context.
Fuel us,
right. That understanding that. But there's a part of this for me of how do you get to this core of somebody starting to understand what they themselves are bringing to the table. That it's not all outside, but these biases, these stereotypes, these views, I'm carrying into my deliberations. I'm carrying, and oftentimes making the problem worse. How do you build that capacity for self-reflection?
Well, if we had been successful, then we wouldn't be having arguments with our own peers, because they're the very people you're talking about. And I know some of the ways that don't work. Sarcasm, calling people out by name, which is why I was a little embarrassed when I did that on that film you saw last week. Gina probably hasn't seen it. She'd say, naughty Paul. So, I mean, those, you could be, Muhammad Ali would just knock them out, right? But to be effective, in other words, if we're just trying to win the argument, we'll win, right? But that's a very hollow sense of satisfaction out of winning an argument when you're trying to understand, to change. So, you just brought up, self-reflection and awareness and the cultivation of discernment. I've heard you do it before, and that's what you're talking about. That's got to be a big part of it. And it's hard, it's hard as I find it difficult, And I notice that when we bring this up among first-year students in our social medicine class, one of the first things we hear is, "Oh, we already know about bias. We already know about racial disparities.
I know the definition."
And we would never do that.
Right.
And yet, somehow we do. And then it's probably too cheap to say, well, it's structurally determined, there's nothing we can do about it. So
I want to challenge you on one part, because you mentioned what doesn't work. But what happens when you don't name the elephant in the room?
I shouldn't have said it doesn't work, okay? Because we can all find examples in which it does work. Right. One of the ones that has struck me most is AIDS activist. taking precisely those tactics, but they also complemented their efforts with the pragmatic solidarity of thinking about the provision of care. And again, this at a time when some people were just willing to write off the provision of care, and not just in Africa. This happened in Mississippi, Louisiana. There were state lotteries for these new medications, you know, and or I could go right through the list. So it's not just about over there. So that, you know, that's to me a very important model.
Right, and being strategic in naming it. So I think about when I turn on the television or look at my smartphone and see the divisiveness and the anger and the disrespect and the devaluing of individuals. And in that space, what happens if you don't name it, if you don't call it out? And what are the risks that are there? So understand being sort of strategic and tactful, but are there moments when you have to just say, this is wrong or you're wrong?
Yeah, I think it probably happens on a daily basis. Now, avoiding sanctimony or smacking of it is another challenge. But you know, at some point after the Civil War, Reconstruction fell apart. At some point after the Civil War, Jim Crow came in place. Those Confederate statues weren't put up by grieving widows in 1866. Those were the work of legislators and white supremacists who not only had local backing, but translocal backing. In other words, you know, if President Grant said, no, we're not going to let this happen, which evidently he did, somebody later said, oh, well, it's, you know, it takes a long time, or, and so I think naming problems, we were talking about that one, is an important part of this undoing. And, you know, that's a very commonplace thing to hear, truth and reconciliation in South Africa, Gacaca in Rwanda, but I've seen some pretty remarkable things happen in Rwanda in a fairly short amount of time. And I guess that's why some of what I've been seeing with this divisive, or feeling rather, with what we've been seeing as Americans has been, in addition to maddening, it's been saddening. You know, it's just very tragic. And then, you know, then you realize, look, if we don't go through more personal discernment, or if the medical profession says, well, you know, that's not really us, it's not really our job, that, you know, obviously we're not going to move forward quickly enough.
I think that and understanding.
Or slip backwards.
There's a couple of things. One, this importance of coalitions, and sometimes those movements of medicine come outside of medicine. So as we look back and you trace this sort of history of civil rights and justice in medicine, it wasn't medicine that integrated the hospitals. It wasn't medicine that said we'll give blacks privileges in our hospitals. It was a legal system that came in. And so sometimes medicine, as much as we may talk about equity and justice and those types of things, we need pushes from outside to act.
Absolutely. And if you look at the assault on affirmative action, which is an ideological and legal assault, the fact that there exists any, I mean, Thurgood Marshall's dissenting opinion after one of those reverse discrimination judgments from the Supreme Court was, I'm sure I'll mangle it, but the basic idea was, you know, it's just bizarre to assert that there's no legal remedy needed to undo something that has been going on, which is, he was talking about, you know, the institutional racism has been going on for hundreds of years. And it's absurd, likewise, to assume that we don't need, as you said, broad coalitions, and to think about all the remedies at our disposal. A lot of our work has been broad coalitions that include community health workers, women's groups, peasant cooperatives, et cetera, et cetera. It's also, you know, if we work in a prison in Rwanda, we're talking about prison health this morning in your early engagement. You know, there's only two ways to get into a Siberian prison, let me put it that way, for a doctor. And I would prefer only one of those two. And that involves making coalition, not just with the legal authorities, but with the Ministry of Justice. That's what they call their national legal system. And anybody who's been successful in global health, and I've already said I don't think we're very successful, right? I don't think we're very successful. But anyone who's been successful on a modest level knows there's no other way to do it than coalitions. And coalitions are hard, and they're frustrating. They're also the only way forward. So I can't imagine any ranking problem, even in a resource-rich city like this one, any ranking problem in disparities and bias that isn't going to require that.
Right. And I think with that, as you talk about community workers, this understanding of you have these different methodologies, different kinds of expertise you bring to bear, but people with very different perspectives. So how does the community, how do our patients, how do they bring their understanding of the issues as we come up with our grand solutions that may or may not be on target with what our community needs? Or
Well, you and I, again, agree entirely on this. I wanted to just give an example that you already know about, but many will not. I just came from a meeting with Michelle Morse, faculty member at HMS, the Brigham, and she and some others started this group called Equal Health, and it's related to a number of other endeavors in social medicine, right? Which is not, obviously a term that I care about, and that my colleagues and I hope the students care about, because they have to take it, which is one of the few. This is one of the few medical schools in the United States where those are required in the curriculum, right? Looking at health disparities and thinking through the social determinants of ill health or good health, but also the social determinants of distribution of access to diagnosis and care. And again, the fruits of basic science. And this group, Equal Health, proceeded along precisely those lines. That, yeah, they were mostly physicians and medical students, but they weren't mostly from the United States. When I saw a huge gathering of this last social medicine meeting, or not the last one, one of the earlier ones, there must have been 700 people there, including people I knew quite well from Rwanda and Haiti and all over, most of the United States, but all over. And, but that's not the diversity that you were talking about.
right.
That's not a professional diversity. Those are physicians in training and some other health professionals. That required sitting and listening to people in where they live or where they work, which we often describe as the community.
Right.
I mean, most social scientists don't say the community because Harvard Medical School is a community as well, the Quad, for example. Anyway, it's just that work, where you say, well, we're lucky that we get to go to medical school or nursing school or graduate school, whatever, and we know that we are in institutions that are reflecting these global biases and national biases, national being part of global, but we're going to take active steps to counter them, both that personal reflection that you talked about and often do, that collective reflection as professionals, but then also shutting up and listening to people. And that kind of reverent attention is easy to talk about in medicine and hard to do. Right? Well, it's supposed to be what we do. Same with anthropologists, right? It's easy to talk about. I'm going to be quiet and just listen. But it's very important.
What are the ways we can help our institutions understand the values and things we're talking about and move them in this direction? So there's a part of this understanding this diversity, and there's all types of diversity, but often that's not reflected in who we see within our institutions as we look at our leadership, as we look at our faculty. Our student body at Harvard Medical School is wonderfully diverse, but it's not reflected across the board. How do we move in a direction so that that diversity and that inclusion is truly valued and we get the full benefits?
Well, one thing I just want to say, I think it's only fitting for me to start answering that. I mean, you already know 89% of what I'm going to say, if not 94. But for the benefit of the exercise, I always try to start by saying, Harvard Medical School has given me everything, right? I would never, if I had not been a scholarship student at HMS, I would certainly not have been able to do an MD, PhD here, and then go to the Brigham, and then start right on the faculty. So that's my first thing I want to say, and I would recommend it to others. I mean, and I'm talking about others who define themselves not as some nice little white guy. All right, that starting with gratitude for your own good fortune is a big part of that reflection that you always recommend to us, to your fellows. You know, that's the main thing. Is we're already
this privilege.
We're already these incredibly privileged people, no matter what our background, right? And I also think that gratitude it only makes it easier to be, you know, a voice within a privileged institution for change within it. But I just want to start that way, and not because we're in the Joseph Martin conference room and Joseph Martin is here.
Right.
Really, I swear, I said this before he was dean. You know, it's just I feel like I owe everything. Now, that said, there's no buts. But next, you know. Clearly, if we can celebrate the diversity of the student body, and it's a varied kinds of diversity, as no one knows better than the dean who is tasked with thinking it through. You know, sometimes there is a lack of class diversity, and that's only going to be addressed by active case finding, as the School of Public Health people might say. And I know there are some of you here.
You know, it's interesting, because even as you talk about that, many of our students are they're first generation, and they feel like they are the only ones. And as we've talked about it more, there are many of us, as you talk about your journey here, and lack of privilege, but privilege in being able to come here and move forward. As I think about my journey and my family's journey, as I talk to more and more faculty, their stories aren't told. And there's this myth of who's here sometimes. And I'm wondering if there are ways for us to be more open and sharing about who we are and how we got here. And that might help our students to be more open to exploring their own sort of journeys and this concept of self-reflection. We try to put on a Harvard professor facade, and then behind it is who you were when you grew up and your family and the rest of it. And so really trying to find a space to have those kind of conversations. I think it's about time to open it up to some questions or comments from everyone. There's microphones here.
While you shy people are coming forth, you know, I think there are reasons for someone like me to also mistrust. You know, again, I've just been preach for reverent listening, right? But you're right, you know, maybe it is helpful. I mean, I know that I've learned a lot from listening to medical students, from listening to people at the Brigham. I'm talking about my colleagues. Again, starting with your own privilege, if at all possible. And for us, it should be possible. Because I keep saying, you know, I keep thinking, I often don't say it, but I'm going to say it here. You know, sometimes the discussions that I've heard within universities, research universities, not just this one, you know, the discussions are happening as if they're cut off from the rest of the world, right? And I think that's part of the pathogenic force, not part of the solution, right? And you know, it's you know, if you define your institution as the Quad or a hospital, or the Faculty of Arts and Science, I'm not, you know, talking about this one only, but any place, you know. I went to Duke, you know, and I'm still involved at Duke, again with the same kind of gratitude. And I've just heard some of these internal discussions, and I keep thinking, what on earth would someone living in a squatter settlement in Haiti think of this discussion? So divorced from the rest of the world. And you know, you don't always get a lot of applause when you say that in the middle of a meeting about senior faculty diversity or med school. And it's, you know, again, that could just reflect a lack of Ali-esque courage for saying it anyway, right?
That and understanding that the faculty, the students, our trainees, residents, are not the only ones in the institutions who could help us understand. So if we look at our staff, if we look at everyone from the custodial to the park and the others who help make our institutions work, and having conversations with them about their real lives. So if I think about some of our programs where individuals on our staff are able to bring their children into programs and to see their children having the potential to be a future doctor or a future whatever. So how do we break down some of the bridges in our own institution? You have somebody on a microphone?
Thanks, Dr. Reed and Dr. Farmer. Early in the Ebola response, one of our colleagues, when asked in an interview to describe the Ebola response up until that point, I'm talking maybe July or August of 2014, she described it very appropriately as racist, period. And I think caught a lot of grief from that, certainly not from our groups, but otherwise. Can you talk about, and I think she was saying that in a way to address this idea of disparity within global health and Ebola specifically. Can you talk about the moment within the Ebola response that the global community started to take interest and started to decide it was a problem worth their addressing? Thanks.
Is that like a setup, John, so I get to give a disquisition on?
Yes,
I
please.
will happily do it.
Yes,
my
please.
Students here know, and my colleagues. You know, it's a great question, and I'm gonna try to be brief, but not too brief, because it's this is the kind of complexity that we just don't have the time. I mean, we're not given the time to address in global health, as many of you will be thinking of it. But in that particular instance of the current West African epidemic, let me just, you know, the 2013, 2016. This is to me an overlooked point. What did we hear that summer? By the way, I only knew 4 Sierra Leoneans in June of 2014. One of them at Harvard Medical School. All the other 3 also doctors, 4 doctors. By November, 2 were dead of Ebola. And no white American stricken with Ebola died of Ebola, right? And that's because they were airlifted out of that clinical desert here. But what you asked, John, is when did it start? Well, you know, first of all, the claim that it was new to West Africa. How about you, like an HMS student who you know, Cameron Nutt, how about you just go on to Google Scholar and find out that there are several papers showing that it was already present in Liberia and Sierra Leone. That's just, you know, I understand why, I'm just guessing the colleague you're referring to. You know, why is it permissible to not even get that part right? That it was not new, or that the retrospective stories that were held up to be the origin stories, that they really were not ever confirmed because there's no way of confirming things in a public health and clinical desert. So all the way through looking at the previous ones, right, the previous epidemics of Ebola, it's a good way, again, to reflect on disparities, and they're very subtle. What you're looking for me to say, and then I will stop, is that it's when it becomes a threat to us that the world reacts. And the other part is, how do we react? We react with a disease control paradigm, not with a care paradigm. It's a disease of caregivers. That's why it spread, because people care about each other. Nursing and last rites, that's the last step of caregiving, right? Burying the dead. I mean, you don't have to be a Catholic to know that that's one of the 7 corporal works of mercy, right? Anyway, so I personally would argue that a disease control over care response is racist. Now, how do you say that effectively and not alienate the very colleagues of yours, mine anyway, who are totally accustomed to doing things like that in Africa and have been since the end of the 19th century? That wouldn't fly here. You'd say Tuskegee, right? It did fly here, right? Mm-hmm. That's a control over care example, you know, and it's, when I say wouldn't fly, it flies, but then you get busted, right? And hopefully. And I'm not even sure that we got busted yet as far as West Africa and Ebola goes.
You know, it's
not that I feel strongly.
It's interesting that racism is such a charged word, and we're so afraid to say it or to acknowledge its existence. And so we push it aside, which gives it even more power because it's still present, but we're not doing anything about it or acknowledging it. We were talking before, and we're talking about this concept of something that's sort of caged being better than something that's let loose. And when I thought about that was the problem when you think something is caged and you think it's solved and you think it's put away is that you can start to forget that it's dangerous and it hurts. Mm-hmm. And so when I think about some of the issues of racism and these other issues, particularly in the United States and what we're seeing today, where there's this surprise that it's there, it was always there and it's let loose, but that allows us to be able to name it and to do something about it. Maybe we need more spaces where we can talk about racism and not feel this sense that we're being, somebody's talking about us rather than about something that just exists.
Hi, thank you for allowing us all to witness this conversation. I feel very privileged to be in this space right now. I just have a question, maybe going back to the idea of just global health at its core, because when I hear global health outreach, American global health outreach, I think U.S. imperialism.
You think what?
U.S. imperialism. So I guess my question is, if we're thinking about things in a framework of community organizing and this idea of working with and not on behalf of communities, how do you ensure that you as a white man, you as someone working from an American organization are working with and not on behalf of, and how do you navigate that in a space that isn't actually your own?
Yeah, well, I'm going to take that I know that is a sincere question, and so I don't want to sound overly technical, especially after, you know, Joan's soul-ripping suggestion just now, which I hope you all heard. That is, the beast wasn't caged, it never was, and maybe it'd be better if we just didn't fool ourselves. The technical response, first of all, this is a question that I hear very often, almost always in an American university. I mean, it's not something I bump into in Haiti or Sierra Leone. That doesn't mean it isn't being said, although I would be shocked to believe that the people I've lived with for that long in Haiti, who are unable to hold their tongues on many other subjects, would. Now, but I don't know about Rwanda, even though I lived there for 10 years, right? So it is also interesting to me, given Joan's comment just now about, you know, why we don't talk about this more openly here, that question about identity politics I routinely hear in American universities, and pretty much only, like, and I'm just saying that as my reporting of where I hear certain questions and where I don't. Is that fair enough? What you said is about it's an American organization is actually not the case. Partners in Health was set up as if you go back and look at, and I assume you're talking about Partners in Health and not the other organizations I belong to, right? Like Harvard Medical School, the Brigham Women's Hospital. They're actually set up as sister organizations, not as daughter organizations, right? It's when we were starting this organization, the Haitians we worked with had already started it, right? And the Haitian sister organization is called Amis la Santé, which means Partners in Health in Haitian Creole. And in Rwanda, it's Inshuti Mubuzima, which means partners in health in Kinyarwanda, which I'm sure you all speak fluently. So my point is that is baked in, at least as an idea. Now, how do you do that without erasing history and political economy? That's my, ponderous and clumsy way of putting it. But to talk about community organizing in communities already stripped of resources is erasing history, right? Like if you talk to Alabama sharecroppers who were involved in a non-treatment experiment for neurosyphilis or complications of syphilis, and say, no, all right, we need to organize within our communities, but their community includes the medical institutions that design this program and would continue to do so until the Atlanta Constitution exposed it. I think Alan Brandt has taught us in 1972. So the word community, as I said, is a tricky word, but shutting up and listening is not that tricky. I'm not saying I'm good at it, as you can guess by my long-winded answers. But there's two different things, right? So a social justice approach to global health, as opposed to an empire-focused approach. You just said U.S. imperialism, right? And I just described what disease control over care paradigms as born in the late 19th century. Born how? Out of colonialism, right? I'm not denying that that's the roots of many health interventions. I just don't think that's where global health equity comes from. I think that's a rupture with those paradigms. And again, I would credit activism, and particularly AIDS activists, with helping to break that. If I may, when I came here, again, feeling like the luckiest person in the world, which I was, I made a really adventurous trip, not from Harvard to Haiti or back, but all the way across the courtyard to the Harvard School of Public Health for a class, which actually most medical students didn't do, right? And, when I took a class there, thinking, well, this is where you're going to learn about what was then called international health. We actually had clubs called the International Health Club, or this is not a very critical way to think about it. What nation, what empire, where's the role of equity, organizing, activism? These are some of the things you're asking. And that was where I learned, at least for me personally, about the peril of erasing history and political economy, because the recommendations that something wasn't cost-effective, sustainable, or that you could even do this community interviews and surveys, you could listen to what people said and then ignore it as policy. That was very much the case in the 80s, right? So for me, global health is global health equity, not global international health as constituted in the era of structural adjustment, et cetera. I don't want to sound like a windbag. I am, but I don't want to sound like one. This is the rupture, fighting back with redistribution of resources, acknowledgement of historical past, acknowledgement of historical injustices, acknowledgement of things like institutionalized racism. That's what global health should be about. And that's why I think we should just call it global health equity and not global health. Love, Paul.
I have a Twitter question. And it says, how do we allocate efforts to the, quote, right people, places, et cetera, and control for systemic biases?
Well, I'm focusing today on our own systemic biases, right? Mm-hmm. So I've just described again and again, these fatal errors are not made by poor people facing huge burdens of disease. I'm looking at it wherever Twitter is. I haven't quite figured that out. Although we have rude and regular reminders these days. So, since I've already said, I'm talking about us, right? It's about as often and openly as I can. I think that, again, there are sort of quasi-technical answers to that. And one of them is to understand the burden of disease, right? Like, where does this burden of disease sit most heavily? 19th century social medicine folks figured that out, Virchow, et cetera, And the second, though, is in this era of real possibility, given that now, thanks to actually biomedical research, basic science research, if you think of these three, I'm looking at you, this is what you've been fighting for your whole life, right? Not to say, well, we don't care about basic science research, but to say, we want it to be justly distributed. We want our people, not however we mean our people, we want our people really to participate in the production of scientific knowledge and care. By the way, that's another big part of it, to your question. One of the other ways to do that is actually to listen to people when they say, hey, I want to be a doctor or a nurse or a researcher. That happens every day in the places we work in Africa, just like it does here. Mm-hmm. But to get back to this formulaic response, and then I'll hush up again, understanding the burden of disease is not enough. To understand disparities and bias, you have to look at gaps and you have to go look for them, right? Because you could say, well, and again, this is right here at Harvard. Just look at the historical record. To say that the 3 leading infectious killers of young adults in the world in the year 2000, they were in HIV, TB, and malaria. That's not the burden of disease in Boston anymore, or in the Mississippi Valley. It is on that continent in particular parts of it. So there you go, number 1, 2, and 3. For none of them is there a vaccine, effective vaccine? Where's that going to come from? Basic science research. For none of them was there ready available rapid diagnostics. That would require more. They exist, the platforms exist, but this distribution is critical. And then third, we had our peers saying it's not cost effective, not sustainable, not realistic, not. Again, I never heard anyone in Africa who had HIV disease, AIDS, say that. But it was coming from us. So again, just like we haven't yet been busted on Ebola, back to John's question, I think we should reckon with that. It can only be, if you just say racist at the end of the conversation, right. It's the beginning of the conversation. Right. It does reflect and must reflect in a global political economy the belief that some people's lives are worth less than others. What else could it be, right? Of course, now then you get told, lectured, well, no, it's just we're living in a world of limited resources. But they're more limited for some people and unlimited for others. It's the same world.
And some of what might impact that is having some of those individuals represented in the discussions and the decision making and the allocation of those resources.
And that's exactly what AIDS activists helped us to recognize. Survivorship, whether you're talking about breast cancer or we have to embrace that openly. And then you look at survivorship in cancer, for example, and you see that there's again a preponderance of these same social disparities among survivors for varied reasons, but also among those who are engaged in survivorship. So it's not like there's any way of getting away from that basic, the beast was never caged question.
You were waiting longer.
Sam?
Thank you so much. Thank you for this great conversation. I was really excited when I saw the title of this talk because having lived in Rwanda providing care there with HRH, I felt like every week we had a new kind of organization coming in providing aid in one way or another, visiting, and there's so much kind of racism embedded in the way they come in and help in a very different model than PAH is providing. And my question is around, global health has become kind of so popular now in medicine, I think largely as a result of your advocacy and leadership on the subject. And we have all of these trainees, students, residents, fellows wanting to go abroad and do global health rotations. How do we make sure that the rotations that we're sending them abroad for are done in a way that's really sensitive to the bias and racism that's present in a lot of that global health work that's happening? We're sending them out there not necessarily with US faculty to observe, not even necessarily with trusted local faculty to observe, and they're often going in kind of, and they're excited because they get to see new diseases and try procedures they would never get to try at home. I feel really strongly, while I was abroad, never to do anything outside of my scope of practice. I felt like ethically I wasn't there to kind of try new sexy things, but I've talked to leaders in global health, even here in Boston, who are very senior, saying, I opened the book and the child had no better option, and so I did the surgery on the child. I think that wouldn't happen if that child was white. I think think that we're kind of experimenting on black and brown kids. And how do we address that racism as we're sending more and more people out to these global health opportunities and training them for a career in global health? Thanks.
Well, let me make 3 points. Don't worry. First of all, again, we're saying that, I believe we're both saying that we don't think of global health as something over there, right? So that needs, again, one of the minor problems of international health as constituted in the 70s and 80s. In other words, there are lots of major problems, but we don't even share yet an analysis of what global health means, which is why we ought to keep thinking of it as global and adding the E word, equity, every time. Because then we'll be making it clear, back to the wonderful question that was asked about how do you do this to avoid it. That's one thing. But getting back to Joan's challenge, I would say that it is really a good exercise for us to recognize those same sins in ourselves. I certainly know the unseemly excitement of seeing something new, the unseemly desire to do something that, I wouldn't, where I get to feel like I did something heroic. So that's an important part of the process, if I'm reading you right, is that the self-reflection, we'll see that in ourselves. At least I see it in myself. And I'm ashamed of it, right? But I'm very familiar with it. The third part is, again, you can't do what you're calling us to do without acknowledging that history has already happened. History, which is what we're living in the aftermath, whether of Charlottesville or the Human Resources for Health project in Rwanda, right? And again, what would be good, and I tried to do it in my limited interaction with, too limited interaction with faculty, is say, this is going to happen, and on the beginning, as part of their orientation. I said, this is going to happen, and it's not going to be good. But one of the things about listening is, in addition to listening to people afflicted by poverty and disease, the so-called community, which again is, we're part of a medical community, and our colleagues, various colleagues, had a lot to say about this, our colleagues in Rwanda, right? I think listening to them is good, and it's not like they're speaking with one voice, right? But those are 3 things that I would add, is global health is global. I recognize anything that you could say, no matter how bad, I'll recognize it in myself as an exercise because it's an important one. And third, the health disparities are already profound. So a child with an acute abdomen, having one of us, not you, but one of us say, well, I would never do this in that part of the political economy, but I'm doing it here. We should acknowledge then that there will be a very good chance that we get to feel good about something that's still going to result in a death. And that's a very hard process, especially when you're trying to bridge. This is a Harvard Medical School backed program that I think has bridged the most stunning divide, much more than Harvard Haiti actually, and that was Harvard Rwanda in recent years. Now that divide has been lessened by people like you going to serve there. And the right way to do it, in my view, is as, not as like me, a 23-year-old from in between college and medical school, but faculty as well, and people who are experienced and at the height of their powers clinically, working collegially with Rwandan professionals. So.
And raising the Rwandan, and increasing the capacity of Rwandan professionals to act on their own behalf.
Exactly. So,
be a part of it.
In a way, I'm just saying, I think you're choosing one of the least racist global health programs. No, I know you weren't. I'm just saying, that is something Harvard Medical should be proud of. I just was saying to one of Gina Vild's colleagues that this, like the Dean's report ought to have it's an amazing kind of engagement.
I have gotten the wrap up.
But wait, I'm just getting started.
I know you're just getting started. But I have also gotten the wrap up. And want to say,
you're dean too. You can just fight right back.
I'm a dean and an African American woman. I've been told I can take orders from all different places. This side of the room I'm wrapping up, and this side of the room I can take one more question. So one more question.
Okay, thank you, thank you. So to that point, there's a question about kind of channeling power for good. Common scenario, a person of means, a celebrity, shines a light on a global issue, and the funds come in and the resources go at it. Can you speak to how to channel that power while being mindful of bias? And I guess there's a danger in sort of, following the celebrity to the cause. How can we kind of spread that mindfulness out and be more equitable about it?
Spread the mindfulness out.
Yeah.
God, you guys are tough. Meaning, I don't know. I wish I did. I'm doing my best up here, okay? I get uncomfortable with that. So it's kind of, to the question about HRH, Human Resources for Health, that was a great question that she just asked. I'm talking to you over there. Where'd you go?
Sam?
I'm praising you. This discomfort that I may feel when there's a celebrity-directed Angeli-style approach to something, it's really not about me. It's really not about us. I do still feel uncomfortable, just like I feel uncomfortable about, the unseemly enthusiasm that I saw in myself and see in my American colleagues when they suddenly show up in the clinical desert. Like, where you been, surgeon? But I'm glad they're there, right? And I'm glad we're there. And I'm glad that there is someone there. Now, the next question is, okay, makes me uncomfortable, makes you uncomfortable, why? And again, that's restoring history, to understand that. I don't understand celebrity culture, even though I tried for many years to read the Journal of Popular Studies, People. I don't understand how that works. There are sociologists and anthropologists and psychologists who do study that, right? But I'm very reluctant to be entirely dismissive and sanctimonious, and to above that, I don't want to be close to it, but it's not about how I feel, right? Because it's about the materiality of the social. Again, it's about a fact of disparities. So if a celebrity fights to ban landmines, or to eradicate polio, or to take on breast cancer in Uganda, I will be very, very careful to understand that I don't have breast cancer in Rwanda, and I don't have polio, and I do have clean water. Thank you, Matt Damon. You know what I'm saying? I worry about, again, our university-based ethics that kind of erase history and politics. Not yours, but I'm saying it is something I've seen a lot in privileged institutions. Let's go to the corporate world, right? To have a workshop on diversity, of course they can all afford those kind of workshops ad nauseum, if that's not mean to say. But that doesn't mean that a corporation is actually, it may have a diversity inside. It doesn't mean what happens, in which they don't, by the way, but it doesn't mean that changing the makeup of, let's say, the board of directors is going to alter a fundamentally extractive process. Yeah. And I think that requires hard-nosed analysis. And I would try and do it, or be part of a team that does it, or fields questions from people who might be affected. And so that's why I would again try to shut up and hold my tongue and sort through something that involved celebrity-based addressing of our attention deficit disorder to social suffering and poverty and structural violence. And again, I know that's not a short answer, but I'm just explaining my own caution, And when you say, well, the beast has never been in the cage, and we all need to address it, another way of saying it is, and President Obama said this at the end of his service, is that we really need to be happy warriors, right? Like, we're fighting for social justice, but our own grumpiness is not really the point. He didn't say all that, but that's how I would interpret it. And I would say the same about celebrity-based ADD treatment. It doesn't last long, but sometimes you get a chance to pull a lever, you know, where people, I'm more comfortable working with activists, you know, who are going to be at this for years.
Thank you.
So no more questions. I thank you. I thank you
stick
for your
around, though. For those of you standing, I'll stay around. I didn't mean to interrupt you.
Thank you for your attention. I think part of what I would say is that all of us have a role to play, and sometimes before critiquing other people's roles, we need to step back and look at our own. And you don't always know another person's heart or mind or intent. And it's actually together that we're able to accomplish. There's a saying I got from my mother that I is like the I in the word individual. And we, W-E, is like the we in power. And it's when the we come together that you can actually have the power to create change. And so it's how do we work together to create the change. And so I want to thank Paul. I want to thank my friend for this. I want to thank Harvard and Talks at 12 for this opportunity for us to have this dialogue. And I'm going to end with a quote from somebody that in no way makes me think of disparities, bias, or social justice. But they said something that I think makes sense. And I'm going to quote Henry Ford. It doesn't come to mind in this space. And Henry Ford said, "Whether you think you can or you think you can't, you're right." And we've talked about these, what can seem daunting problems and daunting issues. And part of this is your frame of mind. Part of this is being a happy warrior. Part of this is being willing to take on the problems and issues and create the change that's needed. And that's what we all need to be about. Thank you, Paul.